Okay, thanks, Marcia. So, thanks a lot for giving me the opportunity to give a community talk with Capital Health. I had all sorts of nostalgic memories of the first time I did a community talk in the old Oasis snack bar area of the old Mercer Medical Center when I went into practice now 30 years ago. So I hope to do as well as I did way back then. Tonight we're going to talk first, as I understand it, about coronary artery disease, which remains the number one killer in the Western world. And I'm going to look at the cardiology medical side, and then we'll get some very good dietary and lifestyle information from Elizabeth after I hit some of the nuts and bolts here. So anyway, I'm with Capital Cardiology Specialists. Been now part of the organization for years and getting to see lots of patients and still enjoying it after all these 30 years. Tonight, we're going to have objectives of understanding coronary artery disease and how we might prevent it from hurting ourselves or our loved ones. We're going to focus on risk factors and their impact, and we're going to touch on preventative maneuvers as well. I've been allotted 25 minutes to cover a lot of ground. I may at times move quickly or they may leave some things out as we're going along, but we can always pick up some of those in the Q&A. As I alluded to a moment ago, leading causes of death in the United States. This is information from the CDC and the NIH, and this is for the year 2022. I chose this particular slide because I wanted to at least give us a sense of something that was happening in a very real way for a lot of us, a lot of our families, a lot of our coworkers just a couple of years ago, and to have at least some relation to what was going on with COVID back in 2022 to give some relevance to some of these other numbers, because after a while, numbers can sort of get numb and blurring. But in the United States in 2022, we had people pass away to the tune of 702,000, almost 703,000 people from heart disease. And this heart disease number does have a few other components besides atherosclerotic coronary disease, but the vast majority of that 702,880 is the plain old heart attack or complications of trying to treat a heart attack or things like that. The people who passed away from cancer, which has always been sort of in a neck and neck battle with heart disease of who's going to be number one. That particular year, cancer deaths were at 608,000. Accidents account for many people passing away. In 2022, accidents may have been magnified a bit because of a lot of the stress and strain going on with regard to COVID. Actual COVID-19 related mortality directly to the virus and its complications in 2022 was 186,552. People who had strokes were the next in the line there at 165,000. Many strokes are triggered by the same risk factors and by the same mechanism of arteries becoming acutely blocked in an atherosclerotic setting. So when I am talking specific to the heart, a lot, if not all, of the interventions that we would consider availing ourselves of to prevent heart attacks and the attendant angioplasties and bypasses and things like that would also help reduce stroke risk significantly. People who have chronic lung disease was just shy of 150,000. Alzheimer's, unfortunately, is growing in its magnitude as our population ages, and deaths in 2022 were more than 120,000. And diabetes and deaths from diabetes, not ascribable to coronary disease, because we're going to talk about in a moment how diabetes is a huge risk factor for coronary artery disease, was in that year over 100,000 101,209, excuse me. This is the mortality ascribable to diabetes outside of people who had heart disease accelerated by it. So going on to the next slide. Risk factors, some of them are intuitive and we see it all the time. Some are things that bear emphasis. Age is always a risk factor, and dare I say, a risk factor that unfortunately, as we get older, we only get more risk. And so it's a risk factor in a way that we all want to have more of. Of course, we want to have quality of life too, but age, we don't see too many people with heart attacks when they're 30, or that's when they can start. And as people get older and older, the risk just goes up. Gender is a risk factor, and particularly in middle age, males will outpace females, although after menopause, women tend to catch up to men with their overall risk. Family history is a big risk, and if you have at least one first-degree relative who had onset of a coronary problem, especially earlier in life, meaning in their 50s or they're up to mid-60s, then that gets our attention in the cardiology world as to increasing your risk. Cholesterol is a popular and important one because we have tools to address it. And in today's internet age, there's a lot of good information on the internet, and there's a lot of misinformation on the internet about who benefits from simply diet, exercise, and a better lifestyle, and who benefits from appropriate medications. And happy to field questions more about that as we go on. We know sedentary lifestyle is a risk factor that has been more and more important. We'll touch on that more shortly. Smoking is always thought of as a risk factor for lung cancer. It's always thought of as a risk factor for emphysema, COPD. But when you look at the adverse effects of smoking, the amount of people who will die from heart attacks, from strokes, from the atherosclerosis that smoking accelerates greatly, it's at least as much of a cardiac problem as it is a lung problem. High blood pressure is a big risk factor, and one that tends to sneak up on us because very, very often we have little or no symptoms from significantly elevated blood pressure. I talk to patients all the time who will think to themselves that they can't possibly have high blood pressure because they don't have headaches or they don't have shortness of breath. And while high blood pressure can lead to symptoms like that, the vast majority of the time, we actually don't see that. And then again, diabetes, as noted before, is a big accelerant for developing coronary disease. And diabetes not only makes you more likely to develop it, but it also tends to alter the symptoms that you will get from having blocked up coronary arteries, in that the same elevated sugars that can lead to the nerves not working in your feet and your legs, so-called diabetic neuropathy, work on the nerves that go to your heart. And so you often won't sense heart symptoms until your coronary disease is more further along when you have diabetes. Okay, going to the next slide. Just to focus us a little bit, when we're talking about heart disease, in general, we mean coronary artery disease, which is talking about the three coronary arteries that are on the surface of the heart. Even the three coronary arteries is a little bit of a misnomer. We really only have two coronary arteries. We have a right coronary artery here that comes along the right side of the heart. The orientation here is this is the heart of somebody if they were looking back at us from the screen. And on this right coronary artery, in the vast majority of us, it goes around and is the blood supply to the bottom of the heart. And then there's a second coronary artery that's bigger than the right coronary artery called the left main coronary artery. And that main coronary artery quickly splits into two other arteries. Hence, we think about coronary disease as three, but again, really there's two. And that left main coronary artery divides into the left anterior descending, or LAD, coronary artery, and then the left circumflex coronary artery that goes back and out behind the heart, as you can see here. This is meant, our little circle here is a close-up of what a normal coronary artery might look like here. And this is the buildup of atherosclerosis in a coronary artery. And the term atherosclerosis comes, the athero part is Latin for yellow, and sclerosis is hardening or scarring. So this is the yellow scarring of a coronary artery. This can build up in arteries to your brain and the carotid arteries, for instance. This can build up in arteries to your legs. That's where you can get peripheral arterial disease and claudication symptoms. On this last part of the slide here on the bottom right, you'll see a red blood clot that's formed on the top of an atherosclerotic plaque. And the artist here chose to render this plaque as maybe being 60 or 70% narrowed. And one of the biggest breakthroughs that happened starting in the 1990s and into the early 2000s is a recognition that atherosclerosis really has two phases to it. This is a rendering of a very famous slide from a team of researchers that wound up receiving many awards because of what they were finally able to put together. This was published in one of our prestigious cardiology journals back in 1998. And the idea here is that when we're young, and we're even in some cases before we're born, if there's a lot of cholesterol or other risk factors in the biologic world that you're living in, you can go from no buildup of any atherosclerosis, excuse me, to a little bit of buildup here, sometimes referred to as a fatty streak. By the time we get to be a young adult, here in our third decade, you can start to see thickening or buildup of the wall of the artery. And then when we are in our third, fourth, fifth decades, you can see progressive amount of narrowing. In this slide are a couple of very important points. Number one is that this artery here, where I'm pointing, maybe this is only a 30 or 25% narrowing, and you can get that plaque to rupture or erupt like a little volcano looking appearing here when it's much more narrow, around 75%. And the artist puts here a few little red blood cells to suggest a plaque that ruptured, and there's a little bit of a scab, if you will, that's trying to close that off. If this were to erode or rupture, this plaque rupture concept, in this situation and only had a little bit of narrowing, this person might not even know they have that amount of narrowing. But it can also happen when you're at narrowing that's at a 40 or 50% narrowing, or even under some circumstances when it's only a 20% narrowing. One of the reasons for that, and you can see it on this slide a little bit, is you see that the artist is showing us that the artery wall, to accommodate the formation of this atherosclerotic plaque, which is kind of like an abscess. There's a whole lot of cholesterol in there. There's a whole lot of white blood cells in there. There's a lot of inflammation in there. And so the wall of the artery actually gets pushed out. In this rendering, it's getting pushed out some, it's getting narrowed more. But in another rendering that's here, you can think about the buildup can often push the wall of the artery out a lot, and the lumen where the blood is traveling through might actually not narrow very much. And this is going on for decades. And then when this gets to be too inflamed, you can have the rupture of the plaque. Here is a clot and some blood that got into the wall, and then that leads to formation of a clot. That clot can be very small, like on the first picture. It can be bigger, like on this picture, and it might stay in the artery. It might flow downstream this way. It just depends on happenstance. But anyway, the concept here is you can be harboring a whole lot of atherosclerosis and have no symptoms. And in fact, the statistics say that the very first symptom of having serious amounts of coronary disease in about half the people who are destined to have symptoms, the first symptom in about 50% is a heart attack, or a heart attack big enough to cause not enough blood flow to get to a part of the heart, trigger electrical instability and sudden cardiac death. This is an actual pathology specimen that was from roughly the year 2000 on a patient. And this is showing the artery, okay, which I'm circling what the original artery would have been like. And then this area here that looks a whole heck of a lot like butter, and that's part of why I wanted to put this slide into a talk, because butter is really high in saturated fat, and we need to minimize that to help out our cholesterol levels. But anyway, this is a plaque that didn't rupture, but you can see that the wall is being pushed back to some degree. This is not completely circular, but you could imagine that there's still about a 60% of the area open from where this was, and this could have led to a problem for the person who owned this artery. But instead, here's another plaque that shows, this is probably not from the same patient, but it gives you the idea that here is where the artery had been open. This over here is the atherosclerotic plaque. This right here, okay, is where the rupture occurred, and you can see a little bit of clot that got into the wall. And if we were looking at this in 3 dimensions, there's probably a complete connection here with the blood clot that formed. And then over time, a little bit of more clot formed here, and it closed off. And that's likely what triggered the heart attack that led this person's demise. Anyway, pretty dramatic there. I wanted to just give you an idea that, again, this is what we're thinking about when, at least what I'm thinking about, what a lot of cardiologists are thinking about when we're talking about, hey, cholesterol levels need to be better, whether or not somebody needs to be on an aspirin, can we get better control of diabetes? Can we control your blood pressure better? That's the end result when we don't do a good job. Coronary disease, angina pectoris, is the symptom in your chest. Was first described way back right before the American Revolution by a physician in Great Britain and England by the name of William Heberden. And he very much specifically chose the word angina. I'm not going to read through this entire paragraph. This is just his famous quote when he first wrote about it in a medical journal back then. And the term angina, if you look at my cursor here, the sense of chest pain in 1772 that he was trying to capture is not one of sharp pain, but more one of strangling or pressure or tightness in the chest. And he described right from the get-go that typical angina, typical coronary symptoms will come on with exertion and go away with rest. Sharp pain, especially if it doesn't last for more than a few seconds, is practically never really an indicator of a coronary blockage. Here, getting away from all the print there, angina pectoris. Angina means strangling or pressure in the chest. Pectoris is Latin for your chest. It's usually here on this gentleman who's facing us in the middle of the chest, although it can be upper or more lower. It's generally not far off to the left side or very far off to the right side. It's a squeezing or a heaviness or an aching. It'll sometimes have a sense of burning. It's not usually at all sharp or knife-like. Sometimes people describe it as a weight or a band across their chest. When they get this discomfort here, sometimes it'll go to their neck, sometimes it'll go into their left arm, or less likely into their right arm. Over many years, I can't tell you how many times I've talked to patients about their symptoms and whether they were rationalizing or not, or just anxious or scared or really didn't understand. You don't need angina to go into your neck to be angina, and you don't need for it to radiate into either of the arms or into the jaw or into the teeth. It can just be smack dab in the middle there. It is often provoked during effort. This time of the year, every year since I can remember, including this year, someone will be referred to me that when they first broke out the lawnmower and they haven't been doing a whole lot of activity during the winter time, they start to mow the lawn, and after several passes, even a few passes occasionally, they start to get these anginal symptoms in their chest. In the wintertime, in cold weather, it often comes on with snow shoveling. Extreme emotion can be associated with it. And sometimes meals will trigger it because as there's more blood going to your abdomen for digestion, there can be less blood going to your coronary arteries. And if there's a couple of really high-grade blockages in there, you can see where not enough blood is getting to the heart muscle, and that gives the discomfort. Um, Nitroglycerin will make it go away, dilating the coronary arteries, amongst other effects that it has. Other relievers, a big one is rest. Um, Discomfort that comes on without exertion is going to be less likely to be coronary, but it can certainly sometimes be. There are associated symptoms, and the number one by far is shortness of breath. There can also be nausea, vomiting. People often break out into perspiration, and if it's a bigger heart attack, they can sometimes get dizzy because the amount of blood that's being pumped out by the heart that's not getting enough blood flow through its arteries leads to weakness of the heart and lower blood pressure. I should stop here for a moment. There's always been conversation about men and women having different symptoms, and that is probably true. Some of it is societal, some of it may very well be more hardwired, but more times than not, there's a lot of overlap. So you get the tightness and squeezing in the chest when you're pushing that lawnmower, and you also find yourself getting short of breath, and you have to stop to make that go away. Women will tend to, when they relate symptoms about coronary blockages, maybe emphasize the shortness of breath part more. Men tend to emphasize the tightness and the squeezing and the pressure, but again, a lot of overlap with both genders. Um, the duration of the discomfort is very important. Something that's there and gone within a few seconds is much more likely to be related to the muscles of the chest wall, the bones of the chest wall, because of how the nerves work that go to your heart. The duration is usually going to be at least a couple of minutes. And again, if you get it with activity, you almost always have to stop the activity to make it go away. The risks and the targets, we touched on this a little bit, but to give you some more sense of the what we're thinking about for prevention, anyone who's in their 30s and up, we start to think about coronary disease if they've got the right symptoms in their chest. Men will develop their coronary problems earlier than women, but after menopause, women will catch up after about 10 years. Family history is important, but even if you have multiple first-degree relatives with coronary disease, if you do the right things, you do not have to be joining that part of your family club. Generally speaking, for all people, we like to see the LDL or bad cholesterol. Total cholesterol doesn't help us a whole lot, in my opinion, but it's always reported. I can go through that on Q&A if you would like. But the LDL target for everyone is ideally less than 100. And for anyone who has diabetes, anyone who smokes, anyone who has already had a coronary event, we want to see an LDL or bad cholesterol less than 70. And especially after having an event, it's virtually impossible without medication to get down to these numbers. Getting rid of your sedentary lifestyle and getting lots of steps, as an example. A couch potato typically has about 2,000 steps. 10,000 steps is a nice round number. Even when you get 3,000 and 5,000 and 6,000 and beyond steps, you can really help yourself to decrease risk. Smoking, we really need to have zero tolerance for smoking in our lives, or those are the people who are important to us, because it really accelerates coronary risk, probably more than any other risk factor that we have. High blood pressure is an important risk. Medicare has targeted high blood pressure control to a huge degree because after many decades of improving our blood pressure control in the last few years in the United States, our blood pressure control has recently gotten to be a little bit worse. When you're young, 120 over 80 or lower is a good target. When you're in middle age or young middle age to older middle age and beyond, ideally 130 over 80. But over the age of 65, because our arteries do harden, it's still better if it's lower, but we'll tolerate have a blood pressure maybe as high as 140 over 90. Diabetes, as I alluded to, is a very big evolving risk these days because the medications that we treat diabetes with recently have gotten a lot better and better proof showing better coronary outcomes. And there's three classes of diabetes medicines that show that. Some of these are advertised heavily on TV because they're still new and branded. I can go into which medicines as we move ahead because I only have a few minutes left. This is a little bit of levity after those serious slides I showed you a few moments ago. This was actually in the cardiac stress testing lab at the old Mercer Medical Center, which was a forerunner of Capital Health System when I started out. You can see the patient there sitting in the chair, and he's hooked up to the electrodes, and a very senior cardiologist to me at the time would simply pop that balloon, and that would scare that man and make his heart go faster. And of course, Medicare probably didn't reimburse for that one. Anyway, real quick, other ways to fight back, recommendations to the American Heart Association, just some touch points. We'd like to see people get at least 2.5 hours of weekly moderate intensity activity or exercise. We'll hear more about diet, I'm sure, in a moment, but generally speaking, a diet that's low in saturated fat, high in fiber, especially soluble fiber. Mediterranean style diet has become the official American Heart Association diet, so emphasizing monounsaturated fats in olive oil, lots of fruits and vegetables, at least one, if not two servings of marine fish per week, maintaining ideal body weight. We touched briefly on some of the other things to think about for targets to try to prevent your coronary disease. Screening is very important. I stayed away from a lot of slides on that. There are different tests that are coming into vogue more, but the biggest and best way for screening is to sit down periodically with your primary care doctor and do risk scores. The most latest risk score is called Prevent, as in prevention, and Prevent it was from the American Heart Association, came out about a year ago, and you can go online. You can Google Prevent Risk Calculator, American Heart Association, and there's all sorts of fields to enter the different both simple things like your high blood pressure and your gender and your age, and some sophisticated measurements to get a better idea of your cardiac heart disease risk. This is a stress test that's a little bit more advanced from also from the old Mercer Heart Lab from decades ago. And if you can't read the fine print on the bottom, the cardiologist, who again at that time would have been much more senior to me, would have said, for the final part of your stress test, your daughter will ask you about birth control. I have 6 children. Some of them are female. I can tell you that would certainly get my blood pressure and stress up, especially when she looks to be rather young. Anyway, I thank you for your attention. I kept that to 30 minutes instead of 25. I apologize for going over, Marcia, by 5 minutes.
Yeah, no problem. Thank you very much, Dr. Paraboschi. I am going to just spotlight Elizabeth now.
Okay, so we're going to do a little nutrition 101 lesson first and talk about the different food groups that can affect our heart health. Definitely talking about fiber and saturated fats like Dr. Paraboschi mentioned. We'll also identify some foods that can help promote your heart health and then learn how to plan balanced meals for a healthy heart. So just to get started, I like to always review what I call my Nutrition 101 lesson. And when we're talking about nutrition, we're talking about the different nutrients in our foods. There's 2 of them. Our macronutrients are our big ones. They provide calories and energy. And our micronutrients are our smaller nutrients that don't provide calories but are still very important. So we're going to focus first on macronutrients and then touch a little bit on omega-3 fatty acids, but not too much on the micronutrients today. So those three macronutrients are carbohydrates, proteins, and fats. You've probably heard about them. And every single food is either a carbohydrate, protein, fat, or some kind of combination. Your carbohydrates are for your short-term energy, while your proteins and fats are more of your long-term energy. The only place you can get fiber is going to be with carbohydrates. So I have some patients who will say, well, I don't eat carbs, they're bad, but that means you're not going to get fiber, which is very important. Our proteins and fats are not going to have that fiber. They're going to be more for building and repairing muscles and skin. But proteins can have fat in them, and we'll talk about the healthiest options for fat. And then fat is needed for more of our long-term energy, and we're going to talk about these unsaturated and saturated fats. Okay. Before we go anywhere, we do need to know which foods are carbs, which foods are proteins, and which foods are fats. So I like this Venn diagram quite a bit because it kind of helps show which foods go into each category. So just a quick review. Foods with carbohydrates are going to be fruits, rice, pasta, bread, oatmeal, cold cereal, corn, green peas, potatoes, any of our starchy vegetables. We have some foods with carbohydrates and protein, which is going to be things like beans, lentils, and legumes, tofu, soy, and yogurt. And then foods with proteins, which can also have fat, which we'll talk about in a bit. We have our beef, turkey, pork, chicken, fish. A whey protein powder is kind of like a protein drink. Foods with proteins and fats are going to be cheese, egg, shellfish, salmon. And then foods with fats are going to be olive oil, nuts and seeds, avocado, butter, coconut oil, and bacon. And there are some healthy and not so healthy fats. Okay, so let's jump to carbohydrates. People love to say that carbs aren't bad, but that is where we get our source of energy from our brain. In fact, our body needs a minimum of 130 grams of carbs daily. So you keto people are not going to get that. And typically the keto is also going to raise your cholesterol as well. But we have two types of carbohydrates. Simple carbs, I want you to think of turning to sugar very quickly. That's where your juice, soda, sweet tea, lemonade comes in, any honey. And then we have our complex carbs, which are more starch and fiber. If you remember one thing from today, it'd be that fiber is our friend. We love fiber. Your body can't convert fiber into any glucose. So what fiber does is it goes in, it slows down how fast carbohydrates turn to sugar. It picks up all that bad cholesterol that we don't want, makes your colon work really hard to prevent any colon cancer, and then you poop it out with that bad cholesterol as well. So fiber is great, and most people are only getting about 10 grams of fiber a day when your goals are about 25 to 30 grams of fiber. And I'll show you some examples of where we're going to get that fiber from. I really like this graphic because on the left here, you see that there is a whole grain. Think of brown rice, whole wheat bread, whole wheat pasta. And on the right there, you have the refined, which is more of that white rice, white bread. So that grain, that brown part on the outside, your body needs to remove that first, which is going to slow down having high blood sugars. And as the doctor talked before, diabetes and heart disease are kind of a recipe for disaster. So we don't want any high blood sugars. And then that fiber is going to, again, help bind the cholesterol and remove it from the body. So some of that soluble fiber that's going to help the most is going to be things like oatmeal, barley, beans, peas, applesauce, strawberries, potatoes, citrus, and prunes. That's that soluble fiber that's going to help lower the cholesterol. Now, when I say oats, I'm talking more like an old-fashioned or a steel cut. I'm not talking about like a maple brown sugar instant packet. So it's really important to be mindful of the types of foods you're getting and that added sugar as well. Insoluble fiber can play more with your bowel movements. So increasing it too quickly can cause either diarrhea or constipation, but you can find these more in like fruits with the skins, uncooked vegetables, nuts and seeds, brown rice, whole grain flours. So like I said, the goal for fiber is about 25 to 30 grams a day. A cup of vegetables that is uncooked is about 5 grams of fiber, and a half a cup of cooked vegetables is about 5 grams of fiber. So if we add that, have vegetables at every meal, we can get up to that goal of 25 grams, and then adding things like beans and oats to our diet as well. So a couple tips on how to increase your fiber. Things like oat bran, rice bran are nice to have, but on the diabetes side, because I do work in diabetes, we always want to make sure we have protein every time we eat a carbohydrate. I also like things like chia seeds or flax seeds to add to smoothies or oatmeal. Having the whole fruit instead of juice. If I have one recommendation to anyone, stop drinking juice. There's no fiber in there. Some vegetables also have that fiber as well. Brussels sprouts, acorn squash, beans, broccoli, green beans, all have fiber, which can help. Looking for whole grains, so things like whole wheat bread, whole grain pasta, brown rice. One way to do that is looking at the dietary fiber on the nutrition fact label. So if you're looking at 2 pieces of bread, the one with more fiber would be the one you want to go with. Adding beans into your diet, maybe hummus with vegetables for a snack, beans to salad. I love a taco salad with some black beans in there. Having like soups or chilies, we can throw the beans in there as well. Some of our healthy fats also have a little bit of fiber as well, but we'll talk about those healthy fats in a bit. And then if you're really struggling, you hate vegetables, you've tried it all, you can think about adding a fiber supplement, but I'm always food first. So tell me you've tried every single vegetable out there. But some people do struggle with constipation, especially some of the new medications on the market that Dr. Paraboschi mentioned before can cause constipation as well. So if you do need a like Benefiber, Metamucil, that does have that fiber in it, about 5 grams. One of my biggest recommendations for fiber though is as you increase your fiber, you also need to increase your water intake just so we don't get backed up. So the goal for water, as long as you don't have congestive heart failure or kidney disease, would be about 60 to 80 ounces a day. But if you have any issues with fluid retention, I would check with your doctor on fluids. Okay, moving on. So we talked about fiber that's in carbohydrates. We want to talk a little bit about fat. And fat is that thing that can increase the plaque and cause some problems. So fat is really important, but there's 2 types of fats. There's unsaturated fats and there's saturated fats. When I think saturated, I always think the word solid. So any fats that are solid at room temperature, I want you to picture solid in your arteries. So if you leave that butter stick overnight and it doesn't melt to room temperature, it is not going to be liquid in your arteries. It's the same thing with coconut oil. Any of the marbling in your meats, that's not going to melt. That's going to be solid in your arteries. So the main thing I would recommend with saturated fats is limiting those, and I have a list in a bit. Your unsaturated fats, think like olive oil, canola oil, avocado oil, peanut butter. These are going to be things that are liquid at room temperature, so they're going to flow a little bit better in your arteries. The ratio of omega-6 to omega-3 fatty acids can be important as well, but just trying to get those omega-3s in can be a great option for lowering your cholesterol. So this chart here is a really great way to look at different fats. I always say about 80% of the time you want to be in the green or yellow, and then 20% of the time in the red. So you're really limiting the stuff in the red here as much as you can, and then maybe treating yourself here and there. So the top row talks about cooking oils. If you're using anything like butter, lard, ghee, Crisco, coconut oil, palm oil, you want to try to move towards the green section. So could you cook more with olive oil, canola oil, avocado oil? And I do understand that this might be something that you're really used to. You've cooked with butter for your whole life. This is going to be so hard. But these are choices that you have to make, and lifestyle changes are kind of deciding what's more important. Do you want to lower your risk of heart attack, or do you want to have butter? And that's your choice to make. Cooking with olive oil, canola oil, avocado would be better. If you're putting butter on toast, I recommend trying maybe avocado or peanut butter or almond butter. Same thing with like cream cheese. Anything creamy is going to have higher saturated fats. As far as dressings go, if you can't see through the bottle, you're not going to be able to see through it building up in your arteries. So if we want to have a salad dressing, we want to choose more of an olive oil based or vegetable based dressing, like an Italian balsamic dressing. We really want to try to limit the creamy dressings like ranch, Thousand Island, French, Caesar, Russian, blue cheese. And if we are going to go for those, the portion size is about 2 thumbs worth, or about 2 tablespoons. For your nuts and seeds, almonds, cashews, peanuts, these are great snacks, but the portion size is not super big. It's about 4 tablespoons or less than a quarter cup. And coconut is there on the saturated fat, which a lot of people often are surprised about. I usually say for coconut oil, good on the outside of the body, not so good on the inside. For your dairy, it's more of a spectrum. So when it comes to milk, yogurts, you have a high heavy cream on this side of the spectrum, and you have skim milk on this side of the spectrum. Your heavy cream is going to have the most amount of saturated fat, and then we're going to go to half and half, whole milk, 2%, 1% skim. So if you're here on the spectrum, try to slowly make your way down to get rid of that saturated fat. So the only people who should be drinking whole milk are children up to the age of 2 years old. So switch out that whole milk for a 2%, try to get yourself down to a 1%. And I always get, well, 1% tastes like water. Well, yes, again, it's a choice you have to make. And these are the lifestyle changes that you have to ask yourself if it's worth it. Cheese, love cheese, but it's how often you're having it, what your portion sizes are. Okay. Now, proteins are also going to have some fat in them, and we want to choose more of those lean proteins. So same thing here. I am trying to stick in the green 80% of the time, and the medium and high fat only 20% of the time. My trick for that is grocery shopping is only in the green, and when I go out to eat, maybe once or twice a week, that's when I'm treating myself to a burger or sausage. So in that lean fat, that's where we're going to have the least amount of saturated fat. Medium and high fat, that's where those saturated fats start to build up. So the best options for animal is going to be chicken breast without the skin, a greater than 90% lean ground beef. It's a little tricky to find, but you can get it. Ground turkey, greater than 93%. What that means is you're purchasing 93% protein and only 7% saturated fat. So if you're getting an 80-20, that means you're getting 80% protein, 20% saturated fat. It might taste good, but you have to really ask yourself, is it worth it? Chicken and turkey deli meats, beef jerky, those stars are there because that means they're high in salt. So you do need to be mindful about that. In the medium fat section, that's where that higher saturated fat, the chicken thigh, the chicken leg, pork, the sausage, the veal cutlet, and then all the way on the right there, you have high saturated fat, and most of these are also very high in sodium. So your sausages, your bratwurst, bologna, pastrami, hot dogs. Again, you can treat yourself to that, but it's only 20% of the time. Fish and seafood is a great addition. I try to eat salmon, shrimp, cod at least 2 to 3 times a week. You can also incorporate it with tuna, solid white and water. Salmon in the air fryer is delicious. If you can kind of figure out how to do that, I do use a Mrs. Dash lemon pepper on top, which is really great with that. Moving down, I get a lot of questions about eggs. It's not the cholesterol in the egg that's going to raise your Cholesterol, it's the saturated fat in the butter or the lard or the Crisco that you're cooking your eggs in. So I'd rather you have the whole egg and cook it in olive oil than have the egg whites cooking it in butter. So you're kind of making your choices there. You can get a non-fat or 1% Greek yogurt. That again means the amount of saturated fat. Whey protein powder, protein drinks, if you want to add that to like oatmeal to balance out your carbs. And then we have some plant-based proteins like edamame, tofu, pea and soy protein. That just reminds me now, someone had asked me, is a Beyond Burger better or a regular burger better? And when looking at the saturated fat is actually higher in the Beyond Burger. It's a vegan burger because they're using coconut oil to hold the plants together. So that actually, the 80% beef burger is actually higher in protein and lower in saturated fat. So you really need to be mindful when looking at the labels, especially if your vegan options have coconut oil added. So I don't want to take up too much extra time. Let's wrap up with sodium. So sodium is more important when you have congestive heart failure, kidney disease, high blood pressure. The way I describe it is if I put salt on snow, it soaks it up. So if I'm eating a lot of foods with salt, it's going to soak up all the liquids that I'm drinking. More liquids that are staying in my body means there's more blood in my body, which means that my body needs to pump more blood and my kidneys need to filter more blood. So the more fluids we retain, the harder it is that your heart and kidneys need to work. So with sodium, the biggest ones, watch out for your condiments, your Chinese food. I can't tell you how many people got admitted to the hospital after Thanksgiving for congestive heart failure. The amount of salt that's in your prepared foods, bacon, anything canned or packaged. I like to use the guideline of keeping your sodium less than I would say 140 to 300. The easiest way to do it is make sure the sodium in the package is less than the calories in the package because people need about 2,000 calories, about 2,000 milligrams of sodium. So if that's like a 1-to-1 ratio. If I'm buying popcorn and it's only 100 calories, but it's 500 milligrams of sodium, that is way too high. Keeping in mind that your goal for the day is less than 2,300. Some people have a lower goal based on your chronic disease. Okay, so just a couple quick guidelines on the nutrition fact label. You always want to look at the serving size because that tells you how much of what's in the package is listed below. For saturated fat, I try to stick to less than 3 grams of saturated fat per serving. So if I'm looking at a chicken sausage versus a pork sausage, that chicken sausage is going to be a lot less, so I'm going to choose that. Fiber, like I mentioned before, 25 to 30 grams of fiber per day. So if I'm looking at 2 slices of bread, like a Dave's Killer Bread has 5 grams of fiber and a white bread has less than 1 gram, I'm going to go with the higher fiber. And then sodium, I mentioned before, less than 300 milligrams per serving. Most of your frozen meals, sauces, condiments is where you want to pay the most attention to. And Chinese food. Chinese food is terrible, like American Chinese food takeout for diabetes and heart disease. Okay. So as far as what a heart healthy meal looks like, you want to choose those high quality macronutrients, high fiber carbohydrates, lean proteins, and unsaturated fats. You want to do low sodium, so that means avoiding frozen and canned meals, limit cooking with salt. So the 2,000 milligrams of sodium is in 1 teaspoon of salt. That is the tip of my thumb. That is 2,000 milligrams of sodium. So if you're cooking with salt, it is going to add up really quickly. So no salt shaker on the dinner table. Don't cook with salt. I'm a big fan of Mrs. Dash. Limit eating out. I really try to keep it to once or twice a week. Trying to cook more baked, sauteed, steamed, grilled, air fried. Try to limit frying, smoking, and brining, and using those unsaturated oils and fats when cooking. These are what some plates would look like. So this is called the plate method. You want your carbohydrate to be high fiber, the size of your fist. your protein to be about the size of your palm or hand, that lean protein, and then half the plate is non-starchy vegetables. So if I'm choosing brown rice here, I might get 2 to 3 grams of fiber, and half that plate is another 5 to 10 grams of fiber. So if my plate for lunch and dinner looks like that, I can hit my fiber goals. All right, and then just to wrap up, the main points here are choose high fiber carbohydrates, limit foods high in saturated fats, incorporate foods with unsaturated fats like the fish, the olive oil, the avocado, and limit those foods high in sodium. Okay, I think that's all I have for today. I know, Marsha, if there's any questions, we can answer them.
Yes, so a couple things. First, I texted my tech buddy. Neither of us have ever seen those red lines, so we have no idea what it is. I've decided that there's a Zoom curse this week because I also, on my own with her, spent 2 hours last night on another glitch that we were having. So apologize to Elizabeth and the audience. I really, yep, there they are. So maybe we just keep that slide up. The other thing is I am gonna take my spotlight off. For some reason, I can only spotlight 2 people. So let me do that, and I'm gonna have the 2 of you spotlighted instead. We ended up having 65 people tonight, so that is a wonderful turnout. Popular needed program. What is the ideal number of steps per day, and what speed is best on a treadmill?
I think that's more in my wheelhouse. So the best research that was published on this, looking at all the trials that had existed and were published in reputable journals about a year and a half, 2 years ago, actually came from an old mentor of mine at the University of Connecticut, and name's Dr. Paul Thompson. Dr. Thompson's team did a really exhaustive work at looking at even where the numbers of 2,000 or 10,000 steps came from. 10,000 steps is not a number that comes up often in the research, but it was first mentioned in a marketing piece for a old-fashioned pedometer. I believe it was in Japan, according to their report, back in the 1960s. The research that they did suggested that there's a pretty steep benefit to the amount of effort you put in, starting at about 2,000 steps per day, which is a really sedentary person, and you get a whole lot of bang for your buck in terms of not only preventing cardiac events like heart attacks and strokes and needing to have procedures like stenting done. When you went from 2,000 steps up to roughly in the 9,000 step range, that was also mirroring what total mortality benefits there seemed to be. When you got to about 9,000 steps, things started to plateau. There was additional benefit that was had when you went to 13 and 14 and 15,000 steps. But the return on the time and effort started to diminish for the amount of time you were spending. The other thing is when they were looking at these data, they took an entire week. The average would be over the week. So if you have a whole lot of steps on the weekends, but you don't have so many during the week, your number is going to drop down. So 10,000 is not a bad number to try to aspire to. But if you're getting the 5s and the 7s and the 10s, and that's what you're actually averaging over a 7-day week, then you're doing pretty good for yourself. Those steps are better when they're sustained, and the American Heart Association recommends that when we're trying to do dedicated exercise, that you sustain the activity for at least 10 minutes at a time. And if you're a busy person and you can't get all that time to do the activity, you don't need to completely feel that you're not going to be able to help yourself. In those same recommendations, as long as you're in good health, you can get a similar amount of benefit if you're doing 75 minutes of intense activity on a weekly basis, as opposed to the moderate level of activity, that's the 2.5 hours.
What is considered too low for blood pressure?
So that depends on what the illness or not any medical problem that you might have. It also depends a lot on your age. And a big part is it depends on how you feel. So there can be someone who has a blood pressure that's 95 over 60, and they have a very weak heart, and they're on multiple different medicines to strengthen their heart and increase their cardiac output. And they may have no symptoms whatsoever, and they could be 75 or 80 years old, and sometimes we'll take 95 over 60 as perfectly good. On the other hand, there's other people who are on maybe very few medicines, or maybe they're just on high blood pressure medicines and they're getting over medicated, and they feel tired and less listless, and they get dizzy upon standing, and their blood pressure might be measuring 100 over 60 or 70 when they're seated, but when they go to stand up, they're transiently dropping into the 90s and they feel poorly. And in the nth degree, those people can pass out. In general, when the top number, the systolic number, gets into the 100s range, so 110 or below, you start to have to think about, if you're sitting in my chair, is that blood pressure starting to get to be too low? In most people who are middle-aged and older, there's a lot of young people who are in their late teens and early 20s who 110 over 60 or 70, again, is perfectly healthy and very, very expected and almost encouraged.
There's a couple nutrition questions. I'm going to try to get through them. And then I think, Dr. Paraboschi, there's some questions about tech and monitoring. But as far as the nutrition questions go, there's a couple about hydration. I would say when it comes to heart health, especially congestive heart failure, edema, kidney disease, you have to check with your doctor if there's a fluid restriction for you or not. But the typical recommendation is 1 ounce per kilogram, or 60 to 80 ounces. It's typically a good amount. You can overhydrate yourself. That can be an option. Water is boring. Yeah, a lot of things that keep you healthy are boring, but kind of sticking to it is important. You have to be really careful with some of the new products on the market, like liquid IV, some of these electrolyte packets. There's a lot of salt in them, and you may not need that. I don't know, doctor, if you have any other thoughts on the electrolyte packets.
So when we are looking at people who are casual athletes, weekend warriors, and things like that, the electrolyte packets are okay. Most of those people are not going to have too many health issues where I might be concerned about heart failure or the like. Um, the more vigorous the exercise is, in general, the more you're going to need the hydration to begin with, and the more you're going to need the electrolytes in that setting. People who exercise vigorously and will very often, especially if their goal is weight loss, will allow themselves to get dehydrated. And I encourage anybody, when they're thinking about their hydration, to pay close attention to what their weight is before and after they exercise, and the amount of hydration that you're taking in that day, or especially during that exercise, should be enough that you don't lose any weight from the beginning of the exercise to the end. You can use the weight as a surrogate for the fluid balance, and although it's not scientifically 100% true, it's a good approximation that the weight that you lose, if you lost a pound of weight after your session, you're 16 ounces or 1 pint down. Electrolytes with vigorous exercise, especially if it's going to go beyond an hour, you probably want to have something there. There are a lot of different proprietary mixes. The older you get, the more you want to avoid just plain water all the time. But it's a little bit of a case-by-case basis too.
Yeah. It's hard to just say general, overall. The the question about Smart Balance and margarine. So what they're doing when they create margarine is they're hydrolyzing the vegetable oil. So they are changing the bonds to make it solid. Personally, I just don't like the idea of that. So what I do is get the butter with canola oil, but again, I'm not using it often. So my thought is part of it being in the red, part of it being in the green will make it a better option. I'm really only using this if I make mashed potatoes and maybe mac and cheese here and there. But for the most part, like on my toast, in my oatmeal, I'm putting peanut butter or some kind of avocado. The question
So
about ultra.
Elizabeth, if I can interrupt for
Yeah.
1 second, you intrigued me when you were talking about the eggs and to not fry them up in the butter.
Hmm.
Um, I'm 100% Italian background, and I'm very proud to push olive oil any way, shape, or form that I can, because
Awesome.
that seems to be the champion when it comes to overall healthy oils. Um, I often, when I cook eggs, and yes, I am a cardiologist and I do enjoy the eggs because Elizabeth is right that for a lot of us, it may not necessarily bump our cholesterol too much. Um, Basically thinking of it as a spectrum, and wherever I can replace the butter with olive oil,
Mhm.
cooking them together often is what I personally try to do and what I tell my patients. I'm curious, are you aware of any downside of doing that?
On the olive oil.
Right, just putting the two of them together.
Putting butter and olive oil together. I've never
Hmm.
done that personally. When I do buy, I buy the like Land O'Lakes canola olive oil combo. It's already in there, but again, I'm not using it often. My biggest complaints about olive oil is like the smoke point, and some people don't like how it burns. But it's really just how often you're doing it. And the egg thing is something I just get so often. And because I work in diabetes and protein is so important, I'd rather you be eating the protein with the breakfast than skipping the protein because you think eggs are not good. Um,
One of the things about eggs that seems to be the case in a lot of patients I take care of who are trying to lose weight is the trade-off with the some fat being there, some omega-3 fatty acids in the eggs. A lot of protein seems to often lead to more satiety relative to the calories and the fat that's there. And I personally have found more egg consumption to be helpful for me in my weight loss and with patients. Um, I think a lot of it has to do with how much genetically you might tend to absorb molecular cholesterol. Some of us do more, some of us don't. But uh, if you had to give a ballpark egg count for a week, when do you get worried that we're really pushing the envelope with that?
So, the Academy of Nutrition and Dietetics recommends 5 whole eggs a week. I would recommend if you're going to have eggs every morning, maybe do 1 or 2 whole eggs, and then you can do liquid egg whites in addition to it. My fiance eats eggs every morning, but he always cooks it with vegetables. So that kind of balances it out. He's always having like a vegetable omelet. It's always in olive oil. And then he's always having like a whole wheat toast with it. So that high fiber is balancing out maybe a little bit of the saturated fat. So trying to get enough vegetables to go with it is kind of where you're at there.
I,
Um,
I like that approach. Yes,
yeah.
without a doubt.
Yeah, absolutely. And protein is so important for weight loss. And what he was saying there is, so there's 4 calories per gram in protein, and that's going to keep you very full, but there's 9 calories per gram in fat, which also keeps you full. So a small amount of fat fills you up, but has a lot of calories, where the protein is going to fill you up, but it doesn't have as much calories. That's why it's so great for weight loss. So like every time you have a carbohydrate, you want to add that protein with it. So like I will put a scoop of protein powder in my oatmeal so that I'm getting the combination of the two of them. That's going to make you way fuller than just having the oatmeal by itself. And also someone asked about ultra filtered milk. If you're talking about Fairlife milk, I definitely recommend that, trying to get the 1% or the skim milk because it has more protein and less carbs. Marsha, I don't know how much time we have on any other questions.
I mean, it's up to you. I usually like to answer all the questions, but
Okay, yeah.
we do have a lot more, so we might have to, let me see. There was something that said amazing
There,
presentation.
there's a
Um,
couple of, yeah, I'm sorry, go ahead.
you want to
Advice.
just take maybe a few more of them and what just
Yeah.
happened?
I
Okay.
don't mind.
What is your opinion of oat milk? Do you want to read them? It's up to you. You want me to, do you want to read?
Yeah, so the oat milk, there's a lot of negative information on social media about canola oil and rapeseed oil being bad for you. That is not true. So rapeseed oil is canola oil. With the oat milk, they're adding the rapeseed oil to the milk to make it creamy. I personally drink oat milk because there's canola oil in it compared to if I did heavy cream, that's saturated fat. So if I want to froth my milk, but I don't want a saturated fat, I will go with a creamy oat milk because they're using a polyunsaturated or monounsaturated fat to add to that. Almond milk is almond water. You're not getting anything from there. You're not going to get protein either. So you can't use it as a protein. There's one about juicing. No, just no. No juicing. When you juice something, what happens is it removes all the fiber and that goes in the garbage. And the only thing that goes in the cup is water and sugar. You need to eat your vegetables or minimally at least do a smoothie so that the fiber stays in the cup. But if you've ever seen a juicer before, all the fiber just goes out the back, and that is not going to be the benefit of the fruit and vegetables anymore. Just no on the juicing, unless you want diabetes. So that's up to you.
So moving down the list, there's a couple of questions that I wanted to hit before we ran out of time.
Yeah.
One is, what is your opinion on new smartwatches that measure blood pressure periodically throughout the day? My opinion from a practical perspective is they're not as accurate as one uses a more traditional automated cuff to measure your blood pressure. The other thing that's important about measuring blood pressures throughout the day is that the recommended levels of blood pressure are very different for activity than when somebody is seated and at rest for at least 5 minutes, attempting to truly quiet themselves, analogous to working on an engine when the motor is being revved as opposed to when a motor is at idle. And all of the recommendations that we have for treatment are based on someone who has been seated quietly for at least 5, if not 10 minutes. If you want to be really strict with 2 separate determinations of the blood pressure, if you're just looking at a blood pressure that's going on throughout the day, you could run into problems thinking you've got elevated blood pressure when you don't. Also related to blood pressure, and I want to address this only because it's important for that person who's put it out there. But in general, the person indicates that they really never had blood pressure elevation until their husband passed away, and as expected, and they indicate, I please accept condolences for such a loss from us. But if when someone passes, there's a tremendous amount of stress and grief that leads to a tremendous amount of adrenaline that leads to elevation of blood pressure acutely. There's also, though, things that happen in your life that may lead to lower blood pressure, such as often when you're saddened, you don't eat or drink very much, and often people's blood pressures will drop, and they'll have a tendency for low blood pressure, and maybe even being on blood pressure medicine now, they're not hydrated, there's not as much sodium in their system, pressures might get low, that blood pressure medicines might make matters worse. The rest of that question is, did that cause my sudden high blood pressure situation? All I could say is it certainly could have. And if your pressure is elevated, you need to see at least your primary care doctor, if not your cardiologist, to get a sense of which direction in the spectrum you are for the low or the high. And if it is high consistently, then cautious use of blood pressure medication to lower it until there's time for things to hopefully slowly get better over time with grief. But yeah, it can happen, but you really want to stay on top of that because unfortunately, when someone loses a loved one, especially a husband and wife situation, the research says that the increased risk of hard cardiovascular endpoints goes up in the ensuing years. And I have seen that in my own extended family. So yeah, don't just ascribe it to the pressure to be because of that and then not do anything about it.
I wanted us to see if they could answer the one about the cheese, because I think a lot of people have that question. What's the best cheese to eat if you want it sometimes?
Um, I think cheese is more about portion size than anything. But I do like the part skim mozzarella cheese for a snack with like a fruit or something. So you can look for part skim options, but the cheese does add up in saturated fat quickly. But again, like if you're adding cheese to an omelet, also add vegetables to like balance it out. And then part skim is also an option. Yeah, cheese is so good. Um,
So Elizabeth, if I could ask you
yeah, of
a
course.
follow-up on that, because this was something that a nutritionist, dietitian talked to me and made a recommendation about 20 years ago, which is especially hard cheeses and even, dare I say, small amounts of the full fat variety because there's potentially more flavor. If you can leverage that to put on the vegetables that you're alluding to, like a little bit of Parmesan cheese on a lot of steamed broccoli as an idea, um,
Mhm.
you can get something to be pretty flavorful, but yet not bump up the saturated fat very much. Is that a realistic thing to do?
Yeah, and I think it's also about like what you're having in the day. Like if you're choosing skim milk and you're not cooking with butter, the one cheese is not going to put you over the edge. And if you have plenty of the fiber, I think there's not always like a yes and no answer for nutrition, but how do you make it work for the moderation and like your whole day or your habits? Um, yeah.
There were a couple of other questions on a little more on the medicine side. Somebody asked, is it wise to take a baby aspirin when flying? There is no recommendation that I'm aware of for the general public to take a baby aspirin when flying. There are people who do have family histories of forming blood clots or personal histories of forming blood clots. And on a case-by-case basis, your primary care doctor, your pulmonary doctor, your cardiologist could make such a recommendation, but as a general rule of thumb, the answer for that would be no. Someone asked, and this goes back more to Elizabeth's realm as well as mine. Someone asked about arginine and omega supplementation for blood pressure management. Elizabeth, what are your thoughts?
So for omega, well, for any supplements, that's not a regulated industry, so you have to be very mindful. I like to, if you're getting it over the counter and not prescribed, always looking for the USP in a circle. That means that's one of the agencies that will do studies on these. The omega-3 supplements, I take them, the ones from Costco, the fish oil, but if you're allergic to fish, there are options for like flaxseed. But again, I'm always the food first. So change your diet, add your fiber, add your fish in as much as you can, limit your saturated fats. And if your lipid panel is still not looking good over time, then I would possibly recommend adding that in. It also helps for inflammation as well. But you can get omega-3s in foods and not always just adding a supplement to slap a Band-Aid on the problem.
Somebody asked the question, does normal blood pressure exclude someone from having heart problems? And the sad fact is no, it doesn't. High blood pressure is one of the big risk factors, but if you have high cholesterol genetically or by lifestyle, you can certainly overwhelm your arteries even if you have normal high blood pressure. Someone who I know asked the question that I've always wondered about, which is more on the nutrition side, which is what about bananas? Are they good food?
Again, it's very specific because if you have diabetes, then we need to do carb counting. If you have kidney disease, it could be high in potassium. But for the general public, yes, bananas can have, some fiber in it, but I would never eat a banana alone. I always want to pair it with some kind of protein or fat. So whether that's with a Greek yogurt, with some peanut butter. If you have diabetes, it's about 30 grams of carbs in a banana. And if you have diabetes, you can come to our program, of course, and we can work with you one-on-one. But again, it's not always yes or no on the good food. It's really individualized and making an individualized meal plan.
There's a question that came through here that's very medical, and I need to, I want to address it in a general sense. I cannot address it in a specific sense. Someone asks if a person is in their 70s and they've had a stroke and a heart attack previously, is being dizzy in the morning for a week, does that sound alarming? And then question mark, recommend ER or doc visit. I really can't answer that without getting into specifics and talking directly. What I can say in general is morning dizziness can come from blood pressure being too high because blood pressure tends to surge in the couple of mornings before you wake up and stays elevated because of different considerations and hormones that rise to help you get up in the morning. Cortisol and adrenaline levels go up. On the other hand, it can also be you can be dizzy because your blood pressure is low. You can be dizzy because you've got untreated sleep apnea. Absolutely discussion with your primary care physician at a minimum. And if the symptoms are worsening and you feel like you might pass out, they're so bad, then yeah, that certainly could be an ER visit for sure.
There was a question about the companies that this is a tough one, just trying to help my mom. Do you have any company recommendations for those meal ordering companies? HelloFresh for someone who has high blood pressure, high cholesterol, diabetes, and doesn't like to cook for themselves.
Um, the HelloFresh, you do have to cook it. It comes raw. Things like Factor or frozen meals can be very high in sodium. If your mom is of older age, you can look into Meals on Wheels. They do have disease-specific plans, but anything frozen, pre-prepared that you just put in the microwave is typically at least 500 to 700 milligrams of sodium per serving. Unfortunately, cooking ourselves, the more convenient it is, typically the less healthy it is. So it's very challenging. You could also prepare food for your mom and bring it over and have in the fridge. So maybe just bake a bunch of chicken for her, have a pot of brown rice, and maybe some frozen vegetables so that she could just heat that up herself, compared to ordering, because they're going to have a lot more sodium than if you prepare it and freeze it for her yourself.
Anything else that stands out to you? It looks like someone just added one. There's one about, is that true that dietary cholesterol does not significantly raise cholesterol as much as saturated fat, extra sugars do, i.e. shrimp, eggs?
Yes, we talked about that before.
Yeah.
And then I just wanted to know, sometimes people have really high triglycerides, and that's not always related to saturated fats. That's typically more related to refined sugars. So we'll see more high triglycerides with diabetes, but you can also have high saturated fats as well. But if your triglycerides are super high, get rid of the juice, the soda, all that stuff first. But yes, more on the cholesterol in foods doesn't always raise the cholesterol in your body.
To amplify that idea, when we're thinking about treating patients to prevent heart disease primarily, and even more importantly, when we are treating patients to prevent the next heart attack, the lipid profile can be a little bit confusing. The total cholesterol is a number that comes from measurement chemically in, in a laboratory test tube, and that total cholesterol number is made up of the triglycerides. It's made up by the LDL or bad cholesterol, and then an HDL or good cholesterol gets measured, and the relationship there is total cholesterol equals roughly the LDL or the bad, the HDL and the good, and the triglycerides divided by 5. I often see patients very, very concerned about their triglycerides and wanting to get them lower, and normal triglycerides are better than when they're elevated. But the scales are very different. And a change on your LDL or bad cholesterol of 30 points can be really important, whereas a elevation of your triglycerides by 30 points is not a whole lot different than when it was 30 points lower. It's a little more of a problem for developing vascular disease. By far, the best studied and the best way to lower your heart attack risk is when you target the LDL or bad cholesterol, which represents the flux of cholesterol from your liver out to the periphery of your body, where it does both good and bad things. It's very important for all sorts of hormones and function of cell membranes, cholesterol, but if it accumulates in the arteries of your heart and your brain and your legs and so on, it's very bad. But the LDL is the target that when we lower it with diet and exercise, when we lower it with medications, that's where we always get our consistent bang for the buck. And where I encourage everybody to really think about that one as opposed to the other two.
I think that's it. I just want to say some of the comments so you can hear that. Thank you both so much. This was the best one yet. Do this again with the doctor and nutritionist. We appreciate your time. And there was another one that I just thought was really nice that I'm actually going to pass on to my team. I just want to commend you for your dedication and wavering commitment to putting the presentation together. It is one of the best presentations I've participated as an audience. So just so that you get your proper kudos and thank you there. They want another presentation in 3 months. We'll see what we can do.
Absolutely would like to.
Thank you very much to our speakers. Thank you to the audience for coming. Yes, there are support groups for diabetics. Is that true, Elizabeth? Just somebody asked.
Yeah, if you go on the Capital Health website and look for diabetes education, all our programs and education classes are there. For the diabetes education, you do need to have a diagnosed diabetes education, but there's also a general nutritionist that you can ask for a referral or call central scheduling. They do have a general nutritionist in Hamilton that if you'd like to see if you don't have diabetes, but have other things you'd like to work on.
So thank you once again, everybody. I'm sorry we really went over time, but we still have 50 people on, so I guess they didn't mind too much. And I'm sorry though for the speakers that usually we sort of have a hard stop at 7:15, but there were so many questions. So thank you.
All right, thank you.
Thank you as well. Take care, everybody.
Have a great
Bye.
night.
Good night.